So good evening, everybody, and happy Teachers' Day. And this occasion of Guru Purnima, pay my respects and offer my gratitude to all my teachers and all my colleagues and my students who have been instrumental in teaching us so many things in life. Uh, we were waiting for the USI president to join, but he is in Bali and he has expressed that he would join in due course of time. So, with this introduction, I would hand over the proceedings to Dr. Chawla sir and Bobby, and they would go ahead with the program.
Yeah.
Sir, you're unmuted.
Yes, ma'am. Yes, ma'am. Can you hear me, ma'am?
Yes, yes, sir, we can hear you.
Thank you, ma'am. As the initiative of Indian School of Urology, USI, to invite the teacher or the teacher of teachers on this special day, we have the privilege of esteemed faculty and esteemed teachers from the different zones. And may have the privilege of introducing the first teacher of today's special program, Dr. Rajesh Ahlawat. Dr. Rajesh Ahlawat doesn't need a formal introduction to our viewers. He is a world-renowned name in the field of minimal invasive urology and renal transplant. He is credited with establishing a high-volume urology and renal transplant program at different institutes, the prestigious Sanjay Gandhi PGI, Lucknow, Indraprastha Apollo Hospital, the Fortis, and the Medanta now MedCity Gurugram. A very accomplished endourologist, a very fine laparoscopic and robotic surgeon, Dr. Ahlawat has pioneered the world's first robotic kidney transplant with regional hypothermia. A teacher and academician at heart, Dr. Ahlawat initiated urology training, both MCH and DNB stream of urology at different institutes during his association. He was awarded Chakraborty Fellowship by Indian American Urology Association in year 1992 and P.N. Berry Fellowship in 1995. He was honored with the title of Honorary Lecturer conferred to him by the University College London Hospital, UK in 1995 during his stint at Institute of Urology and Nephrology, London. He has pioneered the world's first robotic renal transplant and is credited with establishing successful urology and renal transplant program in India. He is a proctor and mentor of many robotic urologists in India and at international level. We are delighted to have you here, sir, for this day and may I invite you to share your talk with our viewers. Over to you, sir.
Thank you very much. Thanks first of all for considering me, in this elite company that I have. Many of these names have touched my life and have been instrumental in making things happen, how I am here and how I am here today. And I think I was thinking of what to talk. And when I told you that, well, let me talk about how to remain relevant to the students, because that's I thought of, the questions that people ask me the most. And they think that I have been able to remain relevant throughout till now, every part of my life so far. So they asked me this question and I thought that I should find an answer which I should be able to give to them. And second was innovating surgical procedures. It's something which is instrumental to my heart. And we have been able to do that with great efforts. So first of all, coming to the boys, how to remain relevant, I think we have been very lucky. I have been very lucky to be born in an era, when I was trained in open surgery. And then the endourology came, and then in 90s, and then in turn of century, the laparoscopy came, and then robotics came. And then it was a onus on all of us to, initiate programs. And because there was nobody to teach, and we had to learn to teach our boys. So I think I have been lucky to be the right people at right time. I thought so, that, despite, I was at Sanjay Gandhi PGI for 10 years, and I had a wonderful hand with me, protection with me of Dr. Bhandari at that time, who promoted me, who pushed me into endourology. And we took it over and made Sanjay Gandhi as one of the premier centers at that time in endourology. But later on, I moved to a practice in Delhi and at Apollo Hospital, and laparoscopy era had started. So, to remain relevant, I got hold of one of the finest laparoscopic surgeon at that time that was around with me. And he used to work with me for hours and hours together for months and months, despite being in a private hospital. And we initiated laparoscopic program. I called Dr. Shakti Das to start our laparoscopic donor program for the first time in 1998, which was probably the first lap donor nephrectomy being done in India at that time. And we initiated the laparoscopic program. And then, being pushed into robotic prostatectomies and laparoscopic prostatectomy, and then laparoscopic partial nephrectomies, and later on taking over robotic role and getting help of different people at that time. And I just thought that I was lucky, really lucky, to be at the right moment at the right time. But later on, I was listening to a talk by Tadashi, who is the CEO of Uniglobe lately. And he said that people who think that they are unlucky are not going to be successful. And I think you have to turn opportunities to your benefit and feel that you are there and use those opportunities to say that you are lucky and to be successful. So, it was not easy. It's not easy to get the right people, the right help, the right things, but you have to make the most of opportunities to be successful and to get on with the programs to remain relevant. The second thing that I always tell my students to remain relevant is to confine themselves to a smaller field. The most of our youngsters who have been very successful are the ones who have migrated to smaller areas. Youngsters, they are usually not able to leave the charm of being a all-rounder. It's not possible in today's era with so many small areas like pediatric urology, female urology, reconstructive, robotics, oncology, andrology. It's just not possible to be master of everything. And it's much better for these boys to confine themselves to a smaller area, and then they would remain relevant. And these are the two things that I would tell, that use the opportunities and confine yourself to a small area. Choose whatever you like and to remain relevant in life later on. The second part that I would like to tell is the surgical innovations. I had plenty of opportunities while doing laparoscopic surgeries. We had to apply so many things that we had learned during open surgery to laparoscopic surgery. And we used them, invented procedures, modified procedures to the ease. And that's how we developed. But the real challenge that I had in my life was when we developed the program of robotic transplants. And we had a challenge to make it successful and make it foolproof. And we collected the points that were possibly could harm us, that, how to institute regional hypothermia, what sutures to use, what position to use. And what we followed at that time was the ideal guidelines. These are the guidelines which were published by McCullough et al. In 2009 in Lancet. And these, the ideal is an acronym for idea, development, exploration, assessment, and long-term follow-up. So that's how these are the steps one goes through. And this is important for all of these boys to learn, that to go ahead and develop a successful or a new surgical procedures, one has to go through all these steps to be safe and to be successful. So I think that's all that I would like to say today. And with these, I would thank USI once again, and Thanks very much.
Thank you. Thank you very much, sir, for your key messages. I think that one is how you must stay relevant in current day, and the need to focus on certain topics and use the opportunities. I think that was two important messages, how to be relevant, and importance of innovations. I think that's extremely key important to the students, that they need to innovate to stay ahead in these times. I have been given the task to introduce our next teacher of teachers, Professor P.B. Sivaraman sir. He is fondly called by his students and assistants as Professor PBS sir. I actually had a glimpse of him during my MCS days when we went to Madras Medical College for a mock exam. And I saw a very calm, jovial character. And during the conferences, he is always thronged by people, and he always shows his humor side. And he is always called as a very jolly, jovial, and as a no-comms man. His assistants recall how he gave them a free chance and how he mentored them and never exercised his authority. And whenever he was called to troubleshoot, how he made the tense situations calm and relaxed with his jokes and helped them get out of difficult situations. He actually, when he was given a task to start the transplant program, he used to go to Vellore. Every day he used to drive from Madras to Vellore in the morning and return on the same day. And it showed his commitment in starting a program. He is a very committed teacher, and that is shown by the endowment lecture which is instituted by his assistant students in his name in ASU. For me, he is always an evergreen hero. Over to you, sir. Professor P.B. Sivaraman, sir.
Good evening, everybody. Can you hear me? Yes?
Yes, sir. Yes, sir. Please go ahead.
So, thank you very much for an excellent introduction. And apart from my jovial nature, I do have some surgical talents and teaching also. So, which everybody will accept, I think, in our friend circle, especially Rajesh Ahlawat. I know him for a very long time. And today I thought to tell students about certain basic things, because I'm not addressing this talk to senior urologists, professors, assistant professors. I am addressing this to MCH PGs, aspiring urologists, just past urology, and then who wants to have a career. That's few ethical aspects. Is it okay?
Sure, sir.
Yes, we can hear you, sir. Now.
Right. Okay. First slide. So, regarding ethics in urological practice, certain highlights I will tell you. I'm not going to talk to you about theory. I'll just tell you certain things. Okay. Okay. This is my picture, which was done by one of my patients. Okay. So, the ethical practice in urology.
We can't see the picture, please.
Pardon?
Not seeing a picture.
I'm not seeing the picture.
Can you share your screen, sir?
Sorry.
No.
Yes, sir. Now we can see your slides.
Yes, you are well aware that urologists are not good in computers. I'm also not good. I just asked the help of my assistant professor. Can you see the picture now? No?
Yeah,
Yes,
we can
yes.
see, sir, now.
Okay. It was done in 1996 by one of my patients. So don't mistake me for that. Right. Next. So what I'm trying to say is the core ethical principles which has been given in all books is autonomy, beneficence, non-maleficence, and justice. Avoiding harm to patients, fair distribution of healthcare resources. The example is if a VIP is having a small dressing and you make the acute abdomen wait for him. This is not correct. So, fair distribution of healthcare resources. Promoting the well-being of patients and respect for patient decisions and informed consent. Okay? So, this is only meant for younger urologists. Okay? So, treat like our own relative. Any patient, whoever comes to seek a cure, must be treated like our own relatives, regardless of their social status, family, economical conditions, appearance, age, race, and mental abilities. Prescribe regimes for the good of my patients according to my ability and my judgment, and never do harm to anyone. This is Hippocratic youth. This is what I usually advise my junior colleagues. Don't worry, just treat them like our own relatives, then the best will come out of you. So, there are some things I wanted to give. I don't want to give a lecture on ethical practice, but in practical aspects, I want to tell the junior urologists, not the professors. Suppose there is a stone in the mid ureter at 4 to 5 millimeter and there is some pain. Immediately don't go and do a ureteroscopy, RARS and DJ stenting and things. Give him a chance. Discuss with the patient, and if there is no complication super added to that, give him a chance to pass the stone with alpha blockers and painkiller. And then if it is fails, then you can do it. So do not jump into ureteroscopy just because you see a 4 millimeter stone in the ureter. At the same time, the varicocele. Usually, varicocele grade 1 and grade 2, the normal sperm count and motility, just because the patient is not getting a child, they go ahead and go and operate it. I don't think that should be a correct attitude. I mean, this is not done by everybody. I'm just saying we should not do, that's all. Same thing for TURP. Without medical treatment trial, in case of a primary acute urinary retention, not even a one trial of catheter removal with medical treatment should be given. I mean, then only we can go ahead with the TURP. Right? Same thing, doing bilateral orchidectomy for a localized cancer prostate in a fit young patient, which is also not correct because we are not able to offer him robotic surgery or radiation or chemotherapy, any of these things, and not given a choice to the patient. Definitely going ahead with going prostate orchidectomy is not correct. So these are all the small bits of advice. I am not saying that everybody is doing it. In case you have a patient like this, avoid doing it. That's what I'm saying. So the another important point is, please do not develop the habit of giving or receiving remunerations and commissions for referring cases. Suppose if you refer a case to cardiology, do not expect him to pay something. Man. I mean, there are certain areas in India, in certain people may do this, but as a urologist, upcoming urologist, you should avoid this. Same thing, referrals should be solely based on good work, results, and word of mouth. We should not think because somebody is giving us some Thanksgiving thing, we should refer cases. You only refer patients for good work only and the good results. Next. So, and strictly the nexus of diagnostic center. Everybody says, sir, you send a CT to me, I will give you some money like that. Strictly no commissions or referral charges for scans and investigation. No unnecessary investigation and no unwanted investigation. And the best marketing manager in your own patient is your own patient who has been treated successfully with full satisfaction of the patient. This you will really realize only when you practice for 52 years like me. Every patient of mine who has been very, very happy always brings 4 to 5 patients within a year. This is my practice and my experience. So, another small point I want to is never badmouth colleagues. Even when the patient lands up with a small complication created by your colleague, professional ethics means you should always, I'm not saying you should go out of the way to support it, but do not badmouth this, saying, oh, this fellow should have done this, I would have done this, that's why it has happened. Please treat the complication, make the patient all right. Never ever tell bad things about our colleagues. It is not professional ethics. Next is, in the early days, for younger urologists, cost of practice, very important. See, I used to do TURPs for 1,500 rupees when I was in Isabel Hospital in 1980. But seeing many patients, operating on many patients at a less cost is preferable rather than doing it the other way around. Because number of footfalls, number of patients you are treated are the main plank in which your practice is going to improve. So do not worry about the cost of the operation, the remuneration you get from them, but do more number of surgeries so that patient will be more attracted towards you. And then there is last but not least, I want to tell you, a good surgeon knows how to operate. A better surgeon knows when to operate. The best surgeon knows when not to operate. This is a very important thing. And the last thing I want to tell you is, please do not neglect or ignore any suggestions from your colleagues, anesthetists, or assistants, because they may have a point which you would have overlooked. So simply do not reject it straight away saying, you don't know, I am the chief, I will do that. Please don't do that. Listen to them carefully and think about them. Is there any truth? Can we implement this in our surgery? If it is possible, please do it and thank them. Okay? These are some of the points I wanted to tell my junior colleagues, not the senior professors who are in the stage, only the students. Okay? Thank you very much.
Thank you, sir. Thank you very much for your erudite presentation and the nice messages for the resident as well as the younger members of our fraternity. I think a good teacher inspire hope, ignite the imagination, and instill a passion for learning. I think that Dr. Rajesh and your talk has instilled that hope and ignited the passion for great learning, keeping in view the ethics as well as the innovation and how to stay relevant in times from both the teacher of teachers. Now we come to the third presentation, that is from Dr. Sudip Chakraborty, our next teacher of teachers. I have a great privilege in introducing him to you all. He graduated from NRS Medical College in 1975 and secured a gold medal in general surgery. He did his junior residency in PGI Chandigarh and he did MS in general surgery from IPGMR Kolkata. He remained a faculty in IPGMR Kolkata as assistant professor, and then head of department. He worked in transplant division of Freeman Hospital, Newcastle, and he is examiner for MCH Urology and initiated MCH Urology course in RGKar Medical College. He retired in 2014, and from that time onwards, he is involved in private practice as a consultant in urology. He has many publications to his credit, and he has special interest in endourology, reconstructive urology, and uro-oncology. With these few words, I invite Dr. Sudip Chakraborty to please share his views on this special day. Over to you, sir.
Thank you so much, Dr. Chawla. And I'm really grateful to the Urology Society of India and especially for inviting me. I do not know whether I am really worthy of it. Still, it's my privilege to have such a chance, opportunity to meet you all. Now, actually, I wanted to present my PowerPoint presentation now. One minute. Forgive me. Yes. Hello. Yes. Actually, see, this my delivery is absolutely meant for the younger generations, and I'm not going to say anything speaking.
Presentation, sir. Is presentation on, sir?
Yes. Hello. Am I audible?
Yeah, you're audible. Is your presentation on, sir? We are not seeing on the.
Yeah, presentation. Start it. Yeah, I think I should. Yeah, thing is, yeah, finish. Thing is, in fact, first, what I told earlier that my absolute this deliberation is only meant for these younger people, younger generation. So I'm not going to say anything new, but I felt that during my entire career, I felt certain things which are extremely important to realize. We know everything, but knowing and realizing are different things. I want to just speak a little bit of philosophy as I have learned from others also, as you have told. Sometimes when I speak of philosophy of life, sometimes people might think that really I'm a bloody fool to give such advice. Please forgive me. I think that it is most important to be a good human being first. Then, and as you was told by Pele, it is important to be a good human being first than a footballer. We should be honest and love people, love our patients. We don't want to be greedy medical criminals. Respect self and people. We should try to achieve happiness and then only success. Uh, the message is to give and forgive. My request to all my younger colleagues to meditate, to be polite at heart. Self-criticism is important to rectify oneself mistakes. Only great people can ask for forgiveness. Most detrimental letter for any individual is the word I. We should try to erase from our dictionary. Now, surgical philosophy, the definition of a genius is ability to do most ordinary things in the most extraordinary manner. We must learn anatomy to the depth. For that, we need to go back to the dissection hall sometimes. Patrick Walsh he revolutionized the concept of prosthetic surgery through anatomy and dissection hall. The surgical philosophy should be to feel and respect the tissue under anesthesia. So minimum dissection as needed, no laceration, no unnecessary haste. The best surgery is when there is smooth post-operative recovery. Choose one or two subjects early in the career, my young friends. Concentrate on it. Dedicate. Innovate. If there is any new idea coming to mind, it is better to write it down and to work on it later. It is better to be master of one trade. Choose one or two subjects earlier in career. Concentrate on it and dedicate. Innovate. And how important is physical examination sometimes and history taking? This is just an example. Sometimes patient comes complaining blood-stained undergarments and wet sheets. But when you ask critically, they will say no blood has been seen in the meatus. We must examine the scrotum. Many times I find angiokeratoma fortis, that is a vascular ectasia, in the scrotum. Lump in the umbilical region, it's most important to examine the scrotum and diary. In cryptorchids, if we find at the same time enlarged heavy testis, otherwise testicular malignancy is the most important possibility. I will just narrate one or two catastrophic incidences which I have experienced. Sometimes in 1995-96, for mid-polar renal SOL, CT-guided FNAC reported clear cell carcinoma. And at that time, naturally, radical nephrectomy was in vogue, and radical nephrectomy was done. Specimen cut open, There was no tumor. The lesson is we should not remove the kidney based on the FNS. It's better even to open the serous fascia to check if there is any. Is it believable? Sometimes the catastrophe happens if we choose the wrong anesthesiologist. An elderly male, I remember, after TURBT, general anesthesia, severe repeated bouts of respiratory spasms and prolonged cyanosis on recovery from general anesthesia. The anesthetist was very reluctant to intubate initially, as he had to run for the next case. Can you imagine? Patient developed cardiac arrest. He was intubated, resuscitated, and then shifted to ICU in a better center, but the patient died later. Caveat is never choose busy, insincere anesthesiologist who is in the habit of running out in haste before proper recovery. Another catastrophe. Elderly male, left ventricle ejection fraction is 45%. Type 2 diabetes mellitus, hypertensive. TURP was done for around 50 grams of prostate or so. Postoperative paralytic ileus is developed from the day 3. There was persistent abdominal distension, sodium and potassium are low. Patient was dyspneic. We just sent the patient for X-ray abdomen. And you know what happened? He was laid on trolley flat. Patient aspirated bile-colored fluid on transit, though he was on rice tube. And the patient died. Another, testicular lump, acute presentation. 40 years male with history of trauma while he had prolonged horse riding from Vaishnav Devi. While he was coming down, he had severe pain, tender left testicular lump. Color Doppler ultrasound of scrotum revealed hematoma in the left testis, and there was reduced blood flow. So suspicion of injury or torsion. The scrotal exploration was done in emergency. Heavy dark testis, 3 times the normal size, thickened cords. Orchiectomy was done. Histopathology reported seminoma left testis with cross hematoma. The blunder was scrotal exploration. Lesson, inguinal exploration in slightest suspicion of testicular malignancy. Elderly male, another case 40 years back almost, open prostatectomy was done by a legendary surgeon. I'm sorry to say, he was my teacher. Rectal bleeding in post-operative first week. Again, DRE was done. A malignant growth was found in the upper rectum. So the first DRE rectal examination was done probably casually. Often I have seen TURP being advised based on ultrasonography, even without doing the DRE. Rectal examination not done. Recently, I got 2 such patients. One may miss prostate. Some of these tips in the TURPs, which I want to pass on to the younger generation. Following TURP, introduce a catheter gently because there is always chance of subtrigonal placement. A nicely done TURP may be spoiled. Lift up the bladder neck by finger in the rectum, fill the catheter, and then guide it. If needed, glide in the catheter over a guide wire. If needed, stretch the catheter with 10 French bougie, guide inside the bladder very, very cautiously. It needs expertise, not for everybody. Do not unsterile the instruments, scope or trolley till the catheter is inside the bladder safely. Now I'm interested in monopolar enucleation resection of the prostate. And for monopolar enucleation, that is TUERP or standard TURP, I do not resect 11 o'clock to 1 o'clock position. The roof strip is kept so that there is no bladder neck contraction. At the floor, 6 o'clock, usually it is better not to resect beyond 5 to 10 millimeter proximal to the veru. There is sometimes a hanging roof. There is a temptation to resect, but I do not resect. Better not to resect. The sphincter is preserved. Now, for the lateral lobes, I'm just at the same time running the video also of enucleation and resection. Simultaneously, you can see I use the Collins knife. This is monopolar. Collins knife I use to enucleate the prostate from the floor prostatic fossa. Just touch, cauterize, and then push with the Collins knife. And you can see, just look at the video. It is better to first mark the distal limits bilaterally. Mucosal incision is given. Then enucleation, both ventrally and dorsally, at least to some extent. Then if one can resect the apical region if needed, even at the beginning. I mean, a few back cuts may be done with caution. No damage to the sphincter, even when the BPH extends distal to the veru. But of course, drop it then. And empty the bladder often. Better vision than iglesias. Quicker resection. It is always better to keep the vision clear, coagulate the bleeders, and then only cut. Do not resect in a bleeding field. Do not create subtrigonal perforation at the onset of TURP. No deep cut at bladder neck initially. I have told these are all meant for my younger colleagues and younger friends. Introduce the scope inside the bladder each time gently under vision for emptying and sucking out the chips. Otherwise, the scope may go subtrigonally. If there is a small capsular perforation, one can plug it with a small chip and then continue resection. Do not hesitate to put the suprapubic drain if you feel so. Usually, I do not use the iglesias system. One may wonder, but I find the outer sheath that is 26 French size is too big for Indian urethra, and there is more chance of strictured urethra. I use the 24 CH sheath after initial dilatation in all cases. If needed, one can incise the meatus and the fossa navicularis dorsally. I use the visual obturator. Usually, I don't need the OTC urethrotom. The inner sheath 24 French of Olympus resectoscope may be used after fixing double channel attachment for irrigation, or one can use the 24 CH center lock Stodd's sheath, which I do, and there is less chance of stricture post-TURP. Monopolar enucleation, it's a mushroom technique, much less post-operative blood loss, no laser, no morcellator. I call it poor man's laser. So that my patients, they don't need to pay the extra for the laser and all this. It is quite cost effective. And of course, for a big prostate, bipolar TURP is of choice. One or two words about ureteral arenoscopy. The avulsion ureter is the most dreadful complication of ureteral arenoscopy. So one must be extremely careful while pushing in the ureteroscope, particularly the rigid or semi-rigid ones. Pre-stenting is always important. So the dictum is 1 step forward, 2 steps back. Remember, we should learn from the animals. A sly fox always makes a sure escape route before touching the chicken. So one shouldn't try to hit the stone unless and until you are sure that your scope is quite loose and you can take it out nicely without avulsion. Abhimanyu did not know the exit way out of Chakraborty. In infected upper tract, always better drain first, PCN, followed by definitive surgery. It is medico-legal important. Most of the medico-legal problems come out of ureter URS, and particularly when I remember some cases where the definitive surgery was done without draining first, and there was medical legal suit. Except drainage, no definitive surgery in any infected system. That should be the golden rule. In orchidectomy, I remember one case, orchidectomy under local anesthesia. There was a pull, and it happened in my case. It resulted in patient had developed cardiac arrest. He was resuscitated, but this is a good lesson. Since then, I'm very careful while doing orchidectomy under local anesthesia. In elderly females, bladder outlet obstruction, sometimes I think it is a bad practice to go for bladder neck resection or incision or something like that. Usually they don't need it. Mostly it is mid-urethral stenosis due to estrogen deficiency. They need periodic urethral dilatation only later on, once in 6 months. I have many happy patients, and there is who come for follow-up and for some 1 or 2 decades. Many elderly females have retrosa underactivity as well. Then add parasympathomimetics once the obstruction is treated. So these are some of these things which I felt important to propagate to our next generation. I'm extremely happy and I'm extremely thankful to you all for giving me this opportunity. Thank you very much.
Thank you so much, sir, for those wise words. And thank you for agreeing to participate in this very special session organized by Indian School of Urology. We move ahead, and it gives me great pleasure to introduce my teacher, Dr. Sulabha Punekar. Before I start sharing my screen, I thought I'll pay my tributes to all the teachers in urology, in particular those who are attending today. Thank you so much for showing us the light. I will share a few features of Madam's career as a urology teacher, and then I'll hand over the mic to her. To make matters easy, I have given her 3 questions about which she's going to be sharing her thoughts. So I'm just going to share my screen. Is my screen visible?
Yes, ma'am. Yes.
Great. So, friends, it gives me great pleasure, and it's indeed an honor for me to give a brief introduction to my teacher, who actually showed me the direction in life and in urology, and I was one of those lucky ones. Dr. Sulabha Punekar, born in 1944, a family where there were 3 sisters and 2 brothers, and there was no doctor in the family. Her father wanted her to become an engineer. She did her schooling from Jabalpur, and interestingly, much against her father's wishes, she decided to take up medicine. So she completed her MBBS in Jabalpur Medical College, followed by MS General Surgery, and subsequently MNAMS, which is now known as DNB Urology, way back in 1980 with Dr. Pardnani as her teacher. Thereafter, in the same department in KM Hospital, she was a reader and subsequently went for higher training for a fellowship in Minnesota in 1984, perfecting her skills of percutaneous renal surgery, followed by 6 weeks at Mayo Clinic with finer nuances of endourological training. And finally, she became head of the department first at Sion Hospital, Bombay, for about a year, and then came back to her alma mater, which is KEM Hospital, as head of the department from 1991 till 2002. Thereafter, she continued as Professor Emeritus. Post-retirement, for a short stint in private practice at Guru Nanak, followed by a teacher in Lilavati Hospital, she stopped urological practice completely. Presently, she enjoys travel. She's actually traveled to Antarctica in February 2019, has written a vlog about it, and she's also been to Chandrashila Trek in Himachal in 2018. Her passion is photography, reading spiritual literature, and she is a fitness enthusiast. To her students, she is known as workaholic, ethical, strict, highly principled, but equally loving. In the end, I would simply say a Sanskrit shlok, which is known to all of us. Om Sahana Bhavatu, Sahanau Bhunaktu, Sahaviryam Karabhavahe, Tejasvi Navadhitamastu, Ma Vidvishavahe, Om Shanti Shanti Shanti. This means, may God protect us both, the teacher and the student. May God nourish us both. May we work together with energy and vigor. And may our study be enlightening and not give rise to something wrong. Om Shanti. With these wise words, I'm going to be moving the camera and the presentation to Madam. And the first question I asked Madam was, what has been that moment when you felt very content about being a teacher? Over to you, Madam.
Namaskar, I bring you greetings from Mumbai. On this Teachers' Day, I would first like to thank USI, ISU, and Dr. Sujata Patwardhan and Anita, who have invited me on this Zoom program. This is the first time I am facing this Zoom presentation, which I am much more scared than any surgical procedure. Before I start, I would like to offer my respectful namaskar to my own teacher, Dr. D.S. Pardanani, who is also, who started our department and who is a prime guru for many of us. The time changes, and with that, the table turns. In my case, the table has turned almost through 180 degrees. And now I am on the opposite side of Anita, who has decided to throw certain number of questions to me, and I'm supposed to answer them correctly. I will try my best. So our first question is, what has been the moment when you felt very content about being a teacher? I don't think I can pinpoint one particular moment as an experience of being a teacher, and that particular moment is enough to be satisfied. I think I have been always full of joy and content throughout my life from the time I was in teaching. Destiny chose me to sit in a chair of urology teacher in a prime institute like GS and GS Medical College and KM Hospital. And as all of us know, in India, the method of teaching urology, let us restrict to urology, it is true for many other specialties true also, that the students, super specialty students are already consultants. But we call them residents because they stay in the campus, in the department. It reminds me of a old ancient way of training or teaching, and it used to be called ashramas then. The Sanskrit words say chhatra ante vasinav shishya. Chhatra is an umbrella. Under the umbrella, that is supervision of a teacher, ante vasinav is on board inside the campus in the ashram. Shishya as students. So the students remain under the supervision, in contact, in close proximity with teacher to learn. Our surgical, medical, and all other clinical faculties in India, we call these students as medical residents. And they stay in the department. They come to the department, stay for the 2 or 3 years time for learning. What do? Both the teachers and the students, they experience, explore, experiment, explain to each other. It may not be always from teacher to student. And when they excel with the degree, they leave the department. While this is happening, most of the teachers expect what is again said in Sanskrit, Shishyat Ichet Parajayam. Here, Parajayam is not really defeat. It means the teacher expects her student to do better than what she or he is. At this senior age of my experience, I'm very happy to state that all of my students, they have gone to various parts of the country and the world. They have excelled in their fields. They are well established. And as it is said, sometimes the teacher is known from the famous students that are present in the world. So I am a very mediocre teacher, but perhaps if you know me, it's because of my students. I was fortunate to get a galaxy of brilliant students. During their stay, I was equally benefited from their knowledge, from their hard work. And with them, I have evolved as a teacher. On this day, the Teacher's Day, I would like to thank all my students to make me teacher of the kind that I was in my life. Now, today is the pinnacle of my joy as a teacher. And that's because Anita, my only girl student in my tenure, is sitting next to me, and she decided to project me as her teacher. All of us know Anita is a very well-known urologist, not only in India, but all over the world. She has traveled for 2 hours or more than 2 hours to reach my place, and she was bent up to put me on the screen today. And I think if she is going to project me as her teacher, this is my highest point of joy in life. Thank you, Anita. Shall we do the next? Okay, now Anita's next question is already there. If born today, would you still take a urology as a career? Yeah, in one word, the answer is yes. I will take urology. Now, this is an hypothetical question, and I think the answer also is going to be to some extent hypothetical. If I am born and asked these questions, obviously I will be born with the knowledge, the experience of urology as it is with me today. I will have additional benefit of having a new body, mind, and intellect. And then what I have to improve today, as I understand, which is lacking at this stage of mine, is the knowledge of data science or artificial intelligence. I think with the new body and brain, it will be easier for me to be a urologist. Now, the next question is much more difficult. My message to aspiring women doctors in context of recent news from West Bengal. I think it's a very difficult question. It's also a very painful situation because all of us, all the medical fraternity in this country must have been going through the same situation, mental condition in last few weeks. The problem is we do not know the truth. The truth, earlier we used to believe some of the news media like newspaper, but recently, we know that there are many media which give us information and we do not know what is the truth. So how do we reach that truth? I have really no solution or advice at this stage, but just a very loud thinking that I have on this subject, I will just express myself. The wrong news. Anita earlier mentioned that there is a wrong news which is coming to us. How do I differentiate at this age also with the discretion capacity to read in between the lines and get the right message? I find myself confused because what comes today is falsified tomorrow. So if we want the truth about any news, what I feel will come only when every person in media, every person in journalism, and as a blanket statement, every citizen of this country should behave honestly to reach the truth. It's very sad that in this country, the first lady doctor was from Maharashtra, Anandibai Joshi, who could never come back and practice. But the first lady who ever practiced in India was from the state of West Bengal called Kadambini Ganguly. And today, in the same state, it's very painful to say that one doctor has to sacrifice her life for getting the things straight, as I understand, if that is the truth of the story behind. Now, Anita's question is, does one lose heart on this? I said no. Feel more charged is going to be futile because it is fighting against the wall. But yes, we can bring reforms. And I'm again repeating, the reforms can come only and only when each citizen, each person in all faculties decides to agree to reform and change for good. Thank you so much.
Thank you so much, madam, and thank you, USI ISU, for giving this opportunity. Over to you, Dr. Chawla. Thank you so much.
We have introduction of Dr. Madhav Kamat by Dr. Santoshi. Is he joined? Dr. Santoshi, over to you, Santoshi.
Yes, thank you. Thank you all. Thank you, USI, Dr. Sujata. I'm really fortunate enough to be here in this August company. Now, I can always say that I'm going to share the screen as well before I begin my talk. So, okay. So any which ways, while it is getting shared, I'm trying here. So I have got this opportunity to introduce my great teacher, Dr. Madhav Kamat. So when I discussed about today's program, his question was, "Are I am now so senior, who knows me?" I said, "Sir, you will be surprised that it is like being Amitabh Bachchan. Even if you are in your third generation, you've got third and fourth generation of students here, and you will find it very rarely that people they don't know about you." So I just take this opportunity to introduce him. Now I'm still trying. I've got a presentation here about Dr. Kamat. Thankfully, in my room, we are sitting 3 generation of urologists. So I've got Dr. Kamat along with me. I've got my residents as well, and I believe they may be able to help me out. Can you see anything here?
No, Santoshi, you have put the desktop screen you have put. You have to
Yeah,
share the.
yeah. Can you see it now?
Not yet. Not yet, Santoshi. First, you open the presentation, and then you start sharing.
Correct. It is already open, and it says
now
share.
you have to stop sharing and then reshare.
Stop and
Stop and reshare.
stop. Window.
Okay.
एक बार सिर्फ बैक जाके
Select PowerPoint open presentation.
ओपन किया.
Open is here. Is open.
Select that.
Yeah. Can you see it now? Let me just see. Can you see it now? Still.
No.
नहीं इसमें
ये वाला
नहीं PPT आएगा. So I should say the entire screen, and
now just एक बार escape इसको minimize कर.
This is share.
इसको minimize. Open.
No luck. Okay, so I think without wasting much time, probably I will just run through about Dr. Kamat's achievements and his earlier years. So Dr. Kamat actually, as everybody knows, he finished his medical education from KEM Hospital, Mumbai, and he completed his master's in surgery way back in 1963. He thereafter proceeded to USA and did urology residency, which was actually right from the beginning. His interest was in urology because. Can you hear me? Sorry. Yeah. So he finished his urology residency from New Jersey College of Medicine, and FRCS from Canada in 1968. He obtained his certification American Board of Urology in 1972. That was the year when I was born. So you can imagine my feelings now. Now, the question comes, how did he land up in the USA? So actually, it's very interesting. He mentioned me, he was helping one of his colleagues to go through the ECFMG examination. And during their training, his colleague told him, why don't you also answer ECFMG? And he ended up answering along with him. To his surprise, unfortunately, his colleague failed, but Dr. Kamat went through the ECFMG, and that's how he landed up in the USA. He also had a choice of choosing between University of Chicago and New Jersey, and he had no clue which university to join. And then he decided New Jersey being probably having better weather, he went over to New Jersey. Now, the Canadian examination also was supposed to be the toughest amongst all in urology, which he cleared in the first attempt. Thereafter, he was holding a faculty position in the USA at University Hospital, and he lived in there nearly for 10 years. So he received double certification in North America. In 1974, for family reasons and for his personal choice, he decided to return to India, and he joined as honorary consultant urologist at Jaslok Hospital, which was supposed to be the first kind of a corporate hospital in Mumbai then. He also attached to GMC, the Grand Medical College, since 1977 as associate professor of urology, and then went on becoming professor and chairman of Department of Urology between 1982 to 1994 at the same institute. Now, his pioneering work has been predominantly in the TURPs. So the history is quite interesting. He had opportunity to work with the great Iglesias, and he was instrumental in fact, contributing his work in devising the continuous irrigating resectoscope along with Iglesias. Actually, I had a photograph of Dr. Kamat with Iglesias as well. His other pioneering work has been in being the first few to initiate the kidney transplant program in India. So he was first in starting the TURP program as well as kidney transplant program in India. He has also been an honorary consultant and chief of urology at Hinduja Hospital up until 3-4 years ago. Currently, he is attached with Sir H.N. Reliance Foundation Hospital as honorary urologist. He has treated many celebrities, including the Dalai Lama, the governor of Maharashtra, Mr. V.P. Singh, and of course, none other than Mr. Amitabh Bachchan as well. His father as well was treated by Dr. Kamat. He also held the prestige position of being president of USI in 2002. So without much ado, I think I will actually hand on the microphone to Dr. Kamat. Last but not the least, he received the BC Roy Award. So we are going to keep it as a question answer, just like how Dr. Anita ma'am and Dr. Punekar ma'am did. And there are a few questions which Dr. Kamat will probably go through. I will just hand on the mic to him. Did we drop out? I think we dropped out from the meeting.
No, you're there. You're there.
Is it?
No, you're here. We can see you.
Please go.
Okay, because I just can't see myself. And one second. No, we are there. Yeah. Okay, so probably we'll just run it on the mobile itself. You can just put it over here.
My coming here was for this reason, because I cannot go.
Even we are struggling. See.
Yeah, you just turn the monitor. That's all. So just turn the monitor so that we can see sir and he can speak.
Yeah. So, yeah. Can you screen sir now? That's the thing.
No, you just turn the screen monitor towards sir.
Yeah.
Yeah, that's fine.
Yeah. Perfect.
So where do I speak?
So, yeah. So now Dr. Kamat is on, sir. The mic is
onto the computer.
Questions you have to
so
ask.
questions are here. So I'm going to lead the questions. So firstly, thank you, sir, for being here. He was very skeptical to come on Zoom because he claimed that he is not technologically savvy, and you can see that even I'm in the same boat. I know that I knew few things about the computer, but when it comes to Zoom, I'm still a little ignorant. So, so my first question to sir is, what made you choose urology over other specialties?
I speak here.
Yeah, you can speak here. Yeah.
But here also.
This is just to show you.
So this is showing you.
Thank you, Dr. Santoshi. But before I even answer the first question, let me tell you, I feel honored to be the recipient of this
USI
sponsored. What do you call that? I was asking.
It's a Special Teachers Day program.
Special Teachers Day program. And I think we have to pay tribute to Dr. Sarvapalli Radhakrishnan, our second president of India, because 5th September is his birthday, as we know. And when people wanted to celebrate his birthday, he said, Ki, if you want to celebrate my birthday, you celebrate the teachers on that day. Because he said that next to the parents, the people who mold a child or even the grown-ups are the teachers. And I think that was very commendable. So in India, we celebrate the Teachers' Day on the 5th of September. Of course, all over the world, the Teachers' Day is celebrated on the 5th of October, but that is because UNESCO made certain changes which gave certain rights to the teachers and all that. Now, what was your first question? Why I chose urology?
Correct.
You know, when I finished my general surgery residency and passed my became a graduate in, a master's in surgery at the Bombay University, I had completed everything that I wanted to do in general surgery at that time. And I had two options. One is to become a full-time person in any of the teaching institutions. So I would have joined as a tutor or assistant professor, or I would have started in private practice. So I asked my teacher at that time, what should I do? He said, you are too young to start practice. So I think you should think about specializing. And so I decided that I would like to specialize. And at that time, I chose urology because I wanted to specialize abroad. And those days, people were never considering settling abroad. They were wanted always to go abroad, get the training, and come back and settle in India. And I thought one specialty which I can practice in any part of India, even smaller places, was urology. Supposing I had to become a cardiac surgeon or something like that, I have to be only in big cities, because those days the facilities for something like cardiac surgery will be only in big cities. But urology could be practiced almost anywhere. Of course, a lot of things have changed now. Now urology has become so much dependent on high technology. But though I'm talking about those days, that is in 1963 when I made that decision. And that's why I decided to specialize. Now, the next question that Dr. Santoshi was asking me is, why did you go to USA? Because those days, urology had not developed in India or in England, in any of the European countries. It was developed very well in USA and to some extent in Canada. And going to USA was the easiest way if you had passed the ECF MG examination and scored very well. Because all you had to do is to find out from the book that is published whether there is any vacancy for urology, take a photograph of the ECF MG examination report and send it there. And they would give you an appointment like that. So I applied at several places and I got positive reply from two places, as Santoshi has mentioned. One was New Jersey and one was Chicago University. I forgot exactly the name of the university. And those days, very few people could guide you as to where you should go. So I chose New Jersey mainly because I wanted to learn more about the TURP, and Professor Iglesias was working there. Also, it was closer to New York, direct flight from here, and all such things. And the weather was more amenable. Anything else?
Yeah. So that's quite insightful. The next question is, this is little tricky because staying in Mumbai and spending your time in Mumbai, you always get exposure with celebrities. So the question is, kindly share your experience whilst treating a celebrity, be it a movie star, cricket player, or a politician, be it a good or bad experience.
You have to be professional in treating the celebrity, irrespective of his status in the society. And the celebrity will also appreciate that. Only thing that extra precaution that you have to take, you always maintain confidentiality, irrespective of whether he's a celebrity or he is an ordinary citizen that is coming to you as a patient. We never divulge any information about the patient to anyone else. But sometimes when a celebrity you are treating, people around you, the secretary in your office or some of your residents, just are likely to be tempted to spread the news that so and so had come and is being looked after. So you have to be a little extra careful to maintain that confidentiality when treating with celebrities, because not not glamorize it unnecessarily, because they would like to maintain that confidentiality. This is true for every patient, but the tendency to glamorize is more with the celebrities. So that's the only difference, and their reaction to you changes from person to person. There is no standard reaction that a celebrity you experience with a celebrity. Some are very good. I have had occasions when I've treated going out of the way some celebrity, and the very next day I meet him somewhere and he looks the other way. And I have had people who are even bigger celebrities I have treated sometime in February, let's say, and they remembered that my birthday is in November, and surprisingly in November I get a nice letter from me with a gift. So your experience with celebrities varies, and it's like any other experience with any human being.
So this is typical of Kamat sir. He will not reveal the name of the person, but I can reveal the person who remembered his birthday and sent him a big gift hamper was again Mr. Bachchan, along with his autographed letter. Now, the next question is, on this Teachers' Day occasion, could you please tell us about your guru who made an impact on you or on your life? So I can proudly say that 3 teachers made impact on my life. One is, of course, sitting next to me. Now, unfortunately, the second one is not amongst us, Dr. Sagade. And the third one is enjoying his retired life in South, Dr. Srinivas. I really feel fortunate to be working with all 3. But I want to know from sir as well, just like how I mentioned, whether he can remember his teachers who influenced his life.
So I also have more than one teacher who have influenced my life. But the one that I really admired is Professor Iglesias, because he was in his 70s when he was working. When I had an opportunity to work with him at New Jersey College of Medicine and develop the initial instrumentation for transurethral surgery. And even at that age, the perseverance that I saw, because those days the mortality rate of open prostate was in the region of 10%. And the transurethral resection reduced it to hardly 0.2% almost. So transurethral surgery became extremely popular. But the major problem in those days was the absorption of the irrigating fluid, giving rise to a lot of complications. And he was working on a continuous irrigation outflow with a continuous outflow so that you minimize the pressure in the bladder during the TURP. So whatever irrigating fluid that goes in doesn't get absorbed into the bloodstream. And he was working on this instrument, which is continuous irrigation resectoscope. And it's amazing. I mean, his devotion to development. He was an advisor to ACMI, which was the largest instrument maker, American instrument maker, American cystoscope makers, something ACMI, yeah, for manufacturers, yeah.
ACMI.
And you should see every time he just walks into the morning, he would say, Madhav, that's my first name. So I found the idea now. Let's work on it. And together, and this went on for months and years. So I was really impressed by the perseverance at his age. And finally, he discovered that continuous irrigation resectoscope and became famous for it. That's why I say that among all the teachers, if I have to pinpoint one, it would be Professor Iglesias. He is no more, of course.
Wow, that's really a story to remember. And so my last question to sir is again a little bit tricky. So the question is, any incidents where you felt that your student taught you something during your entire career? Because you have seen so many students going through, you have had MCA students, MS students, DNB students. So it's like several. Any incidents which you can recollect, sir?
No, there are many incidences where I have learned from my students, and but my memory at this age is not so sharp that I can tell you exactly, good and bad also. But by and large, I have learned good things from them. And again, the devotion and the hard work that they put in, and in spite of all the difficulties, how they surmount those and still keep on achieving the great success and all that. So I have many such good memories about the students, but I don't want to pinpoint any particular. If you
Sure. I think that's great. I think it was a nice interaction after a long time with Dr. Kamat, though I see him at least once or twice a week in the hospital. I'm so fortunate to get taught by him, to get opportunity to work with him. And now we are working in the same department, so I feel really fortunate enough. Thank you, USI, Dr. Sujata, and all the members. And back to the chairman.
Thank you, Dr. Santoshi, and thank you, Dr. Madhav Kamat, also for joining us with us all on today's special day.
Oh, pleasure.
Now, can you hear me?
Yes, we can hear you.
Yeah. So Indian School of Urology acknowledges and appreciates the achievements of our countrymen who have settled abroad, and after being there, who have excelled and scaled to pinnacles of success. I have great pleasure in introducing our first teacher in International Faculty of Eminence, Dr. Inderbir Gill, to you all. Dr. Inderbir Gill is Chair and Distinguished Professor of Urology, the founding Executive Director at USI Institute of Urology. He is Associate Dean for Clinical Innovation at USC. He has many honors to his credit, and let me share with you, especially for the residents and the younger members. In 2005, President of India awarded him the BC Roy National Award for Eminent Medical Person. In 2006, he was awarded St. Paul Medal by British Urology Association for 2006, the highest honor that can be bestowed by the Boss Society. and he has been named Honorary Fellow of Royal College of Surgeons of England. He was awarded the USC Presidential Medal in year 2013, the highest annual academic honor that USA bestows amongst the large pool of faculty and students. He has been listed amongst the best doctors in America for several years now. His primary focus is advanced robotic urology oncosurgery. A world leader in robotic and laparoscopic partial infecting for renal cancer, his team is now focusing on developing novel image-guided targeted biopsy and lesion-specific focal therapy for the treatment of prostate cancer. More than 600 peer-reviewed scientific papers, 55 book chapters, and 11 textbooks, and has been on editorial board of 9 urology journals. And the list goes on. With this, I invite our own Professor Inderbir Gill to talk to our members and residents. Over to you, sir.
Thank you. Thank you, Dr. Chawla. Thank you, USI. It's a real privilege and honor to be invited to say a few words. I just want to compliment Dr. Chawla and his team at Manipal. They have built, you have built one of the premier urology centers in the nation. And I've never been to Manipal, but I can see in the background the building of the Manipal hospital, I'm assuming. It is very impressive. But overall, I too have been privileged to count many distinguished urologists as my teachers. Professor Surinder Singh, Dr. Madhav Kamat, list goes on. But the message I think I would like to really convey to the urology residents at Manipal and in the Urological Society of India is that, it's a true privilege to be able to do something that we love in life in general. It's true privilege to be able to follow one's passion. And if indeed one loves what one does and is passionate about it, then it's not work. It's not work at all. I mean, I feel I'm more fired up today about the research we are doing, the things we are innovating, than I have ever been in my life. And again, the urology is just a beautiful specialty. It allows us to express ourselves in many, many ways, multiple subspecialties within it. And I just feel that, the residents and fellows who are enrolled in various urology programs in India are the cream of the crop. You are as good as it gets. And so therefore, with your God-given gifts and skills and talents, much is expected of you as well. Just to practice, learn urology first and then practice it is excellent, but that's not enough. You are not just here to practice the state of the art, you're here to define the state of the art. And collectively, we can do this, and it is, I think, our sacred duty. Personally, I feel that, first one has to learn how to do something in life. Then one has to become very good at that thing. Then one has to perfect it absolutely to the best of one's ability. And then go further to innovate. And, I feel that it is our duty to contribute to the field, to improve the field, to leave it better than you found it. So I think, at the end of the day, as physicians and as urologists, everybody is going to make a good living. Everybody is going to have food on the table. Everybody is going to be able to take care of their family, et cetera, et cetera. So that is pretty much a given. I think that what we need to rise to is the next step, which is innovating, improving, and advancing things. So I personally feel that innovation is where it is. There is much to be discovered. Many new things that are still here to be further discovered and advanced. These are very exciting times in our lives. I cannot remember ever being at a point in my life, in my career, where new things are being discovered literally on a monthly basis. I am alluding to artificial intelligence. We started off in my personal little story, got to the United States and about 35 years ago, and first, just trying to repeat my residency here. I did my first residency at All-India Institute in Delhi, and then Cleveland Clinic and this and that. And then we started off pushing and developing laparoscopy, and we thought we took it far enough along, and then started working on robotics and helped move that forward. But my personal goal is to first learn something, then develop it, then try and perfect it, and then go past it, then try and kill it and get to the next level. So that's how it happened from open surgery, which is what I used to do in Delhi, to laparoscopy in Cleveland, to robotics in Los Angeles. And now we are, we've been trying to develop focal therapy for prostate cancer, which is coming along very, very nicely. And I'm confident in the coming 3 to 4 years, we're going to get FDA approval for 1 or 2 technologies that will allow focal ablation of prostate cancer, and that'll change the field. That'll change the surgical field for prostate cancer. So you can kiss goodbye to robotic prostatectomy for the majority of patients. And that's the way it should be, because prostate cancer is not killing anybody. Let me restate it. Prostate cancer is not a uniformly lethal cancer. In the PROTECT trial, which looked at 1,500 men, compared between active surveillance, radical prostatectomy, and radiation therapy, followed for 15 years. 15 years, the prostate cancer specific mortality difference between active surveillance and radical prostatectomy at 15 years was less than 1%. 1% at 15 years. Between doing nothing, active surveillance, and our amazing surgery, radical prostatectomy, prostate cancer specific mortality difference was less than 1%. Yet, we rendered many of these men incontinent and erectile dysfunction. And so that's not good. And focal therapy will be able to take care of the prostate cancer oncologic threat, yet be able to minimize the side effects of incontinence and ED. And that is our job, to advance the field. So, the fact that I love to do robotic prostatectomy, it is now my job to kill it. That's my job too, to now get focal therapy going. I think we are moving along very nicely. So stay tuned. But focal therapy is going to be a significant thing. Already is, and will grow in strength. All it needs is one thing to happen: FDA approval, and that's it. That's game over for robotic prostatectomy. For low risk is already active surveillance, so that's where it belongs. Intermediate risk is going to be focal therapy, and high risk, of course, will be radical prostatectomy. Anyways, I'm going into too much detail here, but that's my thinking, at least. And as focal therapy is beginning to get established, we are moving into artificial intelligence. And AI is the name of the game, guys. So certainly for the residents and fellows, AI is not going to replace physicians, but it's going to replace those physicians who don't use AI. And this is a beautiful learning journey for everybody. Just in the next 3 or 4 years, the investments in artificial intelligence in healthcare, just in the next 3 to 4 years, are going to be in the $300 to $400 billion range. Okay, I mean, this is going to change much in what we practice in medicine, and it's going to help unlock newer advances. So as I said, I am more fired up personally today about my research today than I've ever been in my life. I invite all the urologists, faculty, residents, fellows, everybody to really open up our eyes, open up our minds, and really, learn everything we can and contribute in whatever way we can. But again, Teachers' Day is the perfect time. I certainly don't look upon myself as a teacher, but as a eternal student. But it is just a time for ourselves to just rededicate to the constant drive to learn, to be inquisitive, to be humble, to not have dogmatic thinking like this is the way it's going to be, and that's all there is to it. That's just a strategy for failure. But just to be always inquisitive, energized, and learn from each other, ask questions. So for me, it's a true privilege to be part of the urology fraternity. And I want to again thank the Urologic Society of India. I want to thank Dr. Chawla for the very kind invitation. I'm sorry I'm wearing a cap. I just got back from workout. I'm getting ready to go to the operating room, but it's a true pleasure to connect. Thank you again, Dr. Chawla.
Thank you, sir, for your extremely elaborate talk and emphasizing on importance of innovation, and then not to have dogmatic thoughts, and to accept the change and move forward. I am given the task to speak about our next teacher who has been honored today, Professor Dr. Mahendra Bhandari. I have only one commonality with him, is that I am from the same alumnus from where he passed out his MCH, that is CMC Vellore. After his graduation from Vellore under Professor Bhatt, he was served temporarily for a short time in Jaipur, and then for a while in Jipmer, and then he was given an opportunity to be the director of Sanjay Gandhi Postgraduate Institute in Lucknow, which he took it to great heights, and which is shown from all the alumnus which have come out of that institution, and the way he developed the department and pushed the faculty to develop the subspecialties. He is honored with, he is bestowed with Dr. B.C. Roy Award, and also Padma Shri by Government of India. He is currently the coordinator for International Robotic Urology Symposium, through which he actually continues to show his passionate for his teaching. And over to you, Professor Bhandari, sir, for your speech.
Thank you very much. Can you hear me?
Yes, sir.
Yes, sir.
Please, thank you very much for this generous introduction. And it may be rehash, but thank you, Arun. Thank you, USI and ISU office bearers, to have given me this opportunity to share stage with real giants of urology, which are ruling the roost across the globe. I am at a loss whether we learn surgery or we are taught surgery. Perhaps both. And when I take this opportunity to thank my teachers, the most significant component, as Madhav alluded in his speech, if I honestly look back, were hordes of residents and fellows who worked with us. I can recount the surgical steps I learned from them, because the advantage of working with these people were that they were from different institutions. They were best of the best. And hence, I think I will pay a very rich tribute to learn from the residents and teachers. As we are surgeons, let me tell you, surgical event is one of the most significant event in the life of the patient, not only of the disease. And that's, you have an opportunity to shape that event. It's not only we change the internal anatomy, we change the function, we change everything in that patient, including he needs a social readjustment. And that's why it becomes very, very significant. Often I talk to a gathering of young people and I find them fixated towards exciting technologies. I am a fan of technology myself, but you have to put technology. Technology is the mean to an end. It can never be an end. Most of the time we gloat hearing this tremendous excitement surgeons have on performing a surgery. But till date, I don't see a data that technical satisfaction is a surrogate marker for long-term surgical outcomes. It is not. Hence, there are many things. And if I recall my moments in surgery, which I sure without realizing all of you are in that page, that whenever you are pursuing a critical step in the surgery, you are in a deep meditative state. You are in deep meditative state. But the whole thing is you have to rephrase is that to achieve what? Not to achieve, as my revered teacher, Dr. Bhatt used to say in 70s, when outcome research was not much known, it was part of the epidemiology and preventive social medicine. He used to say, there is much, much beyond things than the patient is alive at the end of the surgery. And it is so true. Hence, there are three components. Surgeons derive maximum satisfaction and passion in what they do because they go hard way and there's nothing wrong in that. But your ultimate objective is not only a good outcome as accepted in evidence-based word by your peers, but a patient satisfaction. Hordes of papers on discrepancy between even health-related quality of life questionnaires and actual satisfaction of the patient. We are gunning for the satisfaction of the patient. I would like to give two small parables to remind 2 points. Many of you would have heard Maria Geoffroy Mayer, who won Nobel Prize in Physics in 1963 for her work on nuclear shell model. And this was 40 years after she published the paper. She was watching apple grow hanging from a tree in her garden, and her servant came from a marketplace, totally out of breath. Madam, he said, are you okay? And he said that, Madam, you got the Nobel Prize. He said, don't waste time. I knew 40 years ago. That should be the level of confidence in your work. I don't think many of us emulate that or gun for that. Second example, I would say, most of the time growing in these hierarchical institutes and what you call this egocentric places, there used to be a distance maintained with the patient. I was the outcast because I was never able to treat a patient until I developed intimacy with the patient. And this is where I give example of Richard B. Cattle. Again, you would have heard from Leahy Clinic, Boston, who diagnosed his own cancer. He was the doyen of gastroenteral surgery and stomach cancer. And he diagnosed while operating upon a patient of gastric carcinoma, which was eroding at the back. And then he moved around to mobilize the tumor, and he touched his belly. And he told his assistant, I have a stomach cancer. And that's where it's not the pain everybody has, it's the tenderness which tells you about the cancer. So these are two great examples you have. You have a great opportunity. Only thing is gun for long race horses. Rest of the things you would achieve, as Indy said, that you wouldn't be short of money, you wouldn't be short of name. If you can bring at any cost, a smile on the face of a patient, you earn for your lifetime. I once again thank you for inviting me and giving this opportunity to share my thoughts and listen to the great doyens. When one thing I'll tell you, many times our egos don't let us confess what we learned from others. And when Madhav was telling about the story of Iglesias, my knowledge of Iglesias was Madhav Kamat. It was 1972, I think 1973. I met him for the first time in International College of Surgeons in one of the dinners. Since then, we are great friends. And in those days, he said you could have counted transurethral resectionists on tips. That was the differentiating factor. And I still remember Madhav having told me, answering the question, what is the right inflow and what is right outflow? And he used to say, keep a beaker. In one of the workshops, he said, and make sure that the level of water in the beaker remains the same. I think those are the things I can't ignore. So you learn from anybody and everybody who comes your way. I won't take much of your time. Thank you very much, and God bless you, and God bless your endeavors. I'm sure you will reach the heights we have never known, we have never seen, we could never endeavor, at least in this lifetime. Thank you very much.
Thank you, sir. Thank you very much. Thank you, Dr. Bhandari. Actually, he was traveling with his wife, but he stopped in the way to just share his views with us. Thank you very much, sir. And I think with many thanks to all the teacher of teachers, teacher par eminence, our starting from Dr. Rajesh Ahlawat, Dr. P.V. Sivaraman, Dr. Sudip, Dr. Punekar, Dr. Madhav Kamat, international teachers, Dr. Inderbir Gill and Dr. Mahendra Bhandari. Many thanks to you for joining. I'll just invite Dr. Sujata Patwardhan to please join and say a vote of thanks to our teachers. And before we start with the second leg, which is the HUMOUROLOGY session, ma'am, over to you.
Yeah, thank you, everyone, because I think it was a great learning. I think we learned so many things from so many people. We learned the right way to live, not only the right way to behave, the right way to think. And I think it's for all those who were here, we are definitely touched by your words of wisdom and will be always indebted to you. And thank you very much, everyone. So now we would move to our next session, which we thought that humor is necessary in life. And so our next section is a surprise section because we never did it in ISU and it was Dr. Chawla's idea. And so now I hand over the mic to him and invite Dr. Prabhakar for his surprise event for all of us.
Dr. Prabhakar, are you ready?
Yeah. Thank you.
So,
Thank you,
Dr.
madam.
Prabhakar is my colleague from KMC Manipal. He is Guru Bandhu. And how I know when I joined, I was invited for a conference which was being held by Department of Surgery. It was a state level conference and a good gathering. A lot of people from other districts have come, and there was a general surgeon who was, I think, a unit head. He was very fond of telling good stories of humor and cracking jokes. And he was on the stage. Everybody was enjoying, and the dinner was getting delayed. And suddenly something happens, and one name is asked to come on the stage. And that man goes to the stage. And when he goes on the stage, starts cracking jokes, and people are just holding their belly. Food is late for half an hour and more so, and that man was Dr. Prabhakar. So with this introduction, I have great privilege in introducing Dr. Prabhakar to you, and may we have the same time of which he gave to us when he was in Manipal. Over to you, Prabhakar.
Thank you, Chawla, and thank you, USA. Good evening to everyone.
You know, on Teachers' Day, it's a great day, and I remember I called up my beloved teachers. Am I audible? Am I clear? Hello.
Yes, yes, of course.
Yeah, okay.
You're clear.
I called up my beloved teachers to wish them a happy Teachers' Day, and I said, "I am what I am because of you." They said, "Don't blame us. We tried our best." So, a happy Teachers' Day to all the young, wise, and old people out there who have shaped our careers. When as Dr. Inderbir had mentioned, we have to open our eyes to the next big thing which is happening in this world, and that is artificial intelligence. But at the same time, we should not forget that we have our bounden duty to also take care of natural stupidity. I always give a rose to my wife on Teachers' Day, because no one has lectured to me more than her, to me all these years. And speaking of my wife, you know, the other day I went to a house party hosted by one of my close friends. And as the party was going on, you know, she called me aside and said, "This is the fourth time I'm noticing you going up to the dessert counter and coming back. Aren't you ashamed and aren't you embarrassed?" I said, "No. I just tell them every time I pick up a dessert that it's for you." So, friends, I think you should have humor in life. You should find always a reason to laugh. It may not add years to your, it may not add life to your, years to your life, but definitely will add life to your years. Whatever years you spend here on this earth, you should have a sense of humor, laugh whenever you find time, and always, you know, spend time with friends who can always ignite that spark. And laughter is, as everybody knows, is the best medicine. And I've always, I'm inspired by great humorists like P.G. Wodehouse, David Allen, and our own Professor Lakshmipati from Coimbatore. Yeah, I think if any of you gets a chance to read his books written by him, you should. He's a great humorist, and also other stand-up comedians like Richard Pryor, Carson, and of course, not to forget our late Dr. Lakshman Prabhu, with whom I have shared many a lighter moment. I think are the human beings the only people with the sense of humor? I think so, except that probably I've heard of hyenas laughing. You must have heard of hyenas laughing. Speaking on the subject of animals, let me share a few jokes about animals. The first one, I think you should just picturize this. Just close your eyes and picturize this. There is this bear and a rabbit out shitting in the woods. So the bear turned to the rabbit and asked him, "Hey, Mr. Rabbit, have you got any problems of shit sticking to your fur?" Rabbit said, "No." So the bear picked up the rabbit and wiped his backside. On the subject of animals, once again, there was this farmer who was having a lot of bulls and cows, and he started, and as the mating season was closing by, he decided to separate the cows from the bulls. So he built a wall separating the cows, and he put a barbed wire over it. Now there is one young bull, who was very amorous. He wanted to, somehow cross over, and he was roaming around trying to find an answer. So some of the older bulls told him, "Why don't you go and meet this really old consultant bull and ask him for a solution?" So he walked up to the old bull and asked him, "How do I cross over?" So the old bull said, "So you take 60 steps or 60 steps back, then you run at 60 kilometer speed, then you take a 60-degree angle over the wall, go over, finish your job and come back the same way. Then this young bull said, oh, okay, but what if I miss all the calculations? The old bull said, then you can become a consultant. Let's move away from animals. These are real life incidences which I have encountered, humor. So right from my internship days, when I was an intern and I was posted in general surgery, we were going around and my professor had just, doing the general grand rounds, and we had a patient who had undergone a bowel anastomosis. And we all know that after a couple of days, you always ask him, have you passed wind? So my professor asked him, have you passed wind? Actually, this joke is in Tamil, better told in Tamil, but anyway, I'll just translate it. So he asked him, have you passed wind? The patient said, he was wincing, and he said, little bit, sir. So the professor said, what do you expect? Have a cyclonic storm, is it? You will pass little by little only. Then, I was posted in ortho. We have these cyclical postings in ortho. And we had a very famous professor of orthopedics in Manipal. So he was doing one of his grand rounds, and we had, when grand rounds, we have the entourage of assistant professors and then the PGs and then the interns behind him. So he walked into one special ward where he had operated in those days, tuberculosis of spine, and that patient, the lady patient, had a spinal bracket, a brace. And she had been in the hospital for nearly a month. Then this elderly couple. Suddenly the husband of the patient walks up to professor and says, I want to speak to you personally. So professor said, no problem, go ahead. He said, no, sir, only to you. So he said, okay, all of you stay outside. Then something was exchanged. Professor came out of the room and he was fuming. And as he was walking, one of my assistant professors, he had a very good sense of humor. He asked him, what was the exchange? He said, goddamn fellow, aged couple, he's asking me when he can have an intercourse with his wife. He's in a spiny bracket and he wants to know when. Immediately, my assistant professor said, sir, this is a very honest question, sir. He just wants to make alternate arrangements. He wants to know when it is, or he wants to make alternate. And during my MS general surgery days, in the government hospital in Mangalore, we were posted there, and we had a senior PGs. This I heard. I heard from my seniors. There was a very senior PG who was posted there first year, and the first year, the bottom cases are listed towards the end of the list. The clean cases are done, and then the bottom case. So he was asked to do a hemorrhoidectomy. So by the time he got to start, it was almost 2 o'clock. So the assistant professor on call that day told him, okay, I'll be at home. If you have encounter any problems, you just call me. So it went on. So it was almost 5 o'clock in the evening, and he didn't get any call. So he thought probably he must have finished. Suddenly at around 5:30, he gets a call. He said, please come to the theater. So our assistant professor on call that day came. He's a saw gentleman. So he did his FRCS in UK. So he came and he washed up and he said, and our man was, holding on to with the 2 big mops, covering the wound. So he asked him, okay, move over. And then he removed the mops. And he just looked at the place and he said, I asked you to do a hemorrhoidectomy, not an AP resection. So anyway, that person has become a great surgeon, and he's one of the directors of a hospital. So it doesn't matter how good your days were when you were learning your surgical skills. You can always become a great person later once you hone your skills. And then once you become a PG and then you become a skilled assistant during my MS surgery days, I was posted in, during these MS exams. Not MS exams, undergraduate exams, I was a skilled assistant. So you have to arrange the cases and, generally help the students. So there was this repeater. Repeater means we used to call them repeaters, and she was a fairly aged repeater and who had not yet cleared her general surgery. So she was there, and then the external, she did okay. And it was, the internals had decided, let's pass her this time at least. So the external, finally asked her one question. When the examination of the abdomen is never complete without examination of dash. So this girl, she was posed this question, and then she was, trembling. He said, go ahead, madam, answer. She said, the examination of the abdomen is never complete without the examination of the externals genitalia. And I had this senior also when I was posted in urology, who had the habit of singing, always, singing songs, Hindi songs. He was a little aged person compared to us, and he joined EBUS pretty late. So we were in the urology specialty posting. It was a night duty, and in the government Wenlock Hospital, we were called to do a catheterization late in the night. So I was a junior most, and he said, don't worry, I will teach you catheterization, you come along. So we walked up, there was no lift and all, you have to walk quite a distance to the ward. And then he said, okay, he got the catheter, draped everything, cleaned, instilled jelly into the urethra, and then he took that 16 size catheter was the standard which we used to, and he tried to push it in and he could not. Then he told me, see, there is some problem. You go and get a smaller catheter. So junior PG, you have to run all the way, and at 2 o'clock in the night, stores are closed, so you go to knock. And it took me nearly half an hour to get the smaller size catheter. As I was coming towards the ward, I saw this man was sitting there, still holding on to the penis with the urethra. He didn't want the jelly coming out. He was still and he was singing, humming a song. Jab koi baat bigad jaye, jab koi mushkil pad jaye, tumse na saath mein. I started laughing. So such was the situation. And very early in my urology practice, I came across a patient with premature ejaculation. And I tried various drugs in those days, and he was not satisfied. He kept coming back to me, say, doctor, you're not happy. I was at my wit's end. Finally, I tried convincing him. The only way I convinced by saying, see, there is nothing called premature ejaculation. Because women have this bad habit of arriving late everywhere. So there is nothing called premature ejaculation. And have you noticed when you travel in flights, as the plane has landed and is just about taxiing to the halt, half the crowd would be picking up their overhead luggage and trying to get over. I used to call them premature evacuators. And coming to other jokes, just tell me when I have to stop, because Muruganandham also has to share his.
Yeah, Prabhakar, you can just a few minutes, then you hand over to him.
Yeah, you just tell me and I will stop. Okay.
Yeah, one more, and then you can.
Okay. There's this arrogant lawyer from New York. Arrogant lawyer. So he goes duck hunting to Texas. So he shoots a duck, couple of ducks, and 2 ducks fall into a farm, which is, fenced, and it belongs to a farmer. So he trespasses and goes into the farmer's land, and then the farmer catches hold of the lawyer and tells him. Then the lawyer says, you see, I'm a very famous lawyer from New York. I went duck hunting, and the ducks are here. I shot them and they belong to me. So the farmer says, no. They have fallen into my land. You have trespassed, so the ducks belong to me. This lawyer starts arguing, and he says, I'm a big shot lawyer. I can sue you this much. He says, see, now we are in Texas. It's our land. We have a special rule here. The lawyer says, what is the rule? Whoever wants a duck, first has to take 3 kicks to the groin. So the lawyer says 3 kicks to the groin. Okay, no problem. I'm a strong lawyer. I can take it. So the farmer says, I'll go first. So he lands a very big kick to the groin of the lawyer. Lawyer is twitching in pain. He's down on his knees. Somehow he gets up. And then he says, okay, no problem. Then the farmer says, okay, I'll land the second one. Gives him one more big kick to the groin. Again, this fellow falls. It's all birds all over, twinkling bells. He's seeing stars. Somehow he drags himself, stands up. Then the lawyer says, okay, go ahead and land the third kick. The farmer gives him one more kick to the groin. This guy is gasping for breath. Somehow he stands up and he says, okay, now it's my turn. The farmer says, okay, you can have your duck. So with that, I conclude. We'll have, I got many more, but we'll have a different forum to enjoy jokes, humor. Thanks to USI and ISU, Chawla and Madam Patwardhan for giving me an opportunity to be with you this evening. And a happy Teachers' Day once more to all of you. Thank you.
Thank you.
Thank you, Dr. Prabhakar. Though I know you for years, I did not know your writer side. It was very nice hearing to you. I would like to call upon our next speaker, Dr. Muruganandham. He has done his MS from JIPMER and his MCH from SGPG Lucknow. I first time heard him doing a comedy in our Tapasu Khan in Tanjavur. And then I came to know that he has passion for this from the time the COVID started. Maybe COVID kindled his eternal storytelling into comedy, and he found his interest in comedy. He has done more than 25 shows as a stand-up comedian. Over to you, Dr. Muruganandham.
Forgive me, I just, can I have permission to withdraw? Just allow me, please.
Sure, sir.
I
No
enjoyed
problem.
and thank you so much. I've been listening to all of you. Just allow me to leave. Okay, thank you so much.
Please, sir.
Good.
All the
Thank you.
best, all the best, all the best for
Okay.
you, all of you. Thank you.
Okay.
Dr. Muruganandham.
Thanks, Lord, sir. Yes, sir. Thanks. Am I audible, sir?
Yeah, please go ahead.
Yeah. So actually, very few people are there. Probably I like to see the screen page of everyone, and you can all unmute, I think. I will go to the page, all of your faces are there, because I do stand-up comedy looking at the audience, that gives the energy. I request all of you to unmute, to be lighter. I think Dr. Prabhakar has set the platform nicely from such serious and life lessons to lighter moments for the humor. So thanks the USI ISU for the opportunity, and I'll go straight to the story. Thanks Dr. Bobby for the special introduction. So this is actually this is a story about my experience of absurdity and the stupidity of trying to become a social media star in the recent past. So this was a story I like to share with you. And the disclaimer, this is purely, the intention is to laugh, think and feel little bit. Don't take it to your heart. If someone gets hurt, it is purely intentional. Oh, sorry, it is unintentional. Yeah, you can take intentional also, because, and normally what we do is what we taught in the olden days will be little bit tweaked. Please feel at the lower level than you are as a professional. Okay, I'll go to the story. So I am Dr. Muruganandham, a simple guy, happy-go-lucky guy from a small town from the South India. I did my urology training from the great place called SGPGI.
opportunity to join the JIPMER to enjoy my faculty position for 6 years. We had a very good time of doing all types of surgeries, teaching and research. But something happened to me in my mind. Then I had to switch over to a corporate hospital in Chennai. That was my adjustment time in Chennai. So the new city, metro city with traffic and competition all around, a new place to settle, I was trying to find it adjusting. Then slowly I was entering into the phase of my middle age crisis, where there were body and mind changes. I was getting adapted to that. The icing on the top, that's a fuel to the fire. It happened with the COVID. Okay, the COVID lockdown 2020. So the life became sudden standstill. We are all stuck with the fear and the frustration and uncertainty. The number of cases were rising. The mortality was rising. We don't know whether we will be alive. And we were actually under so much of stress. The stress was mounting like anything. At that time, the COVID came in waves, but we had the tsunamis of online webinars at that time. Okay, it was like a big hit. The tsunami after tsunami, many online webinars. And there was a big boom of the Zoom meetings with the impending doom to me. And many of the speakers, actually, they are trying to become more viral than the COVID itself. Coming again and again, conducting meetings or all the associations. So actually, I was very upset. I was upset not because of the meeting, because nobody is calling me as a faculty there. So it was actually not even to chair a session, leave alone giving a talk, not even to chair. So I see my shining younger colleagues occupying the stage everywhere, and my own students, and they were the celebrity surgeons now. They are everywhere. Nobody is calling me. I am left out. The daunting questions started coming to me. Am I still relevant? What I am doing? Whether people like me? Am I doing surgeries or something else? I'll be pushed out of this whole this thing of surgery. That was, I went into the existential problem and the identity crisis. I did not know what to do. So it affected my health, already middle age crisis, adjustment with the corporate life. So one day, actually, I was going through the sleepless night. One day I was trying to get sleep, counting backwards from 1000 to 1. I did not know when I slept. I am a very religious person hailing from South India. Lord Ganesha was my ardent. I am a big fan of Lord Ganesha. That's just telling this thing to him, what is happening. Then I slept off. I did not know when I slept, but that day night, Lord Ganesha appeared in my dream. He came with the same elephant head, with a tusk and a trunk, but with a 6-packs and a cooling glass and a selfie stick with a camera. So he was just doing a moonwalking towards me, and he asked me, "Hi Murugan, how are you?" I was very excited and super enthusiastic to see this, my favorite god. I asked, "Hi bro, how are you?" Yes, I call Lord Ganesha bro, not a friendly bro. We share a common father and mother, Lord Shiva and Parvati, me being Murugan. I call him bro. I said, "Why are you looking upset?" "Oh, see, bro, actually, I am going through this problem. Nobody is calling me for any of the meetings now. I am becoming slowly unpopular. Please help me. You are the destroyer of all obstacles. Please help me." He said, "What happened? Why nobody is calling me to any conferences nowadays?" He said, "You are no longer popular." "Oh, is it? What happened? Why I am becoming so not popular?" "You are not in the social media. What should I do?" "You make some noise, man. You become a social media star. Then you will become the faculty in every conference. Then they will call you in everything." "Oh, isn't it? I don't know about the social media. I'm a simple guy." He said, "Ye chahiye aapko, because you deserve this. You don't even know social media, and you are living and trying to do surgery in this. Then I said, please teach me. Lord Ganesha sat with me the whole night. We ordered a couple of pizzas and he told his mouse to go and get some pizzas for us. We shared our pizzas. He taught me the entire social media on that night in my dream. So what is social media? What are the different platforms? How to make a video and spread it viral, and digital marketing and hashtags and so on. Everything he told. Then he told about the most importantly, he told, my bro, you understand the social dynamics, which is how the social media works. If you want to become a quick, popular, there are 3 groups of people, you follow them. I said, please tell me. The number 1 is the Me Too mongers. I said, what is Me Too mongers? You know, every situation, they will take the opportunity to register their work. Every time they'll make that noise. You can't avoid them. These are Me Too mongers. They become quickly popular. Oh, is it? Yeah, I remember some of the people. Yeah, right. What are the next group? Next group, he said they are obsessive compulsive teachers. Oh, yeah, I could remember someone. What they do? You know, actually, they are self-declared and they taken the entire responsibility of teaching the art of surgery to the entire student of India. They've taken over that contract from the traditional medical schools. Oh, is it? Okay. Then what is the third variety? Let me know. So Lord Ganesha, last piece of pizza he was putting into his mouth, he told, they are called cravers of novelty cravers. Oh, what they do? They know they always look for something new. They always experiment. They make some noise about that. They have the early mover effect. They become popular. Oh, is it? Oh, thanks, Lord Ganesha. It was superb. Then I became little lighter. There was some air of hope for me. I thought I'll go into the action. So I got a new statue of Lord Ganesha in a modern form. I put it in my room. Daily I was praying him. Then told myself motivation, applying to the law of attraction, make some noise, make people to listen to me, look at me. This I was kept at. First thing I tried the me monger route. So I became member of all the groups like WhatsApp, Facebook, Ola, Uber, Tinder. All groups I became the members. And I started making comments in the entire thing. Then I said, in my experience, in my vast experience of 2 cases, I registered my entry. Then nobody was looking at me. There were not even comments, but no acknowledgement also. Then I became slightly more aggressive. I became like I added a drama, little more emotions to that. I started making outrageous statement to become quickly popular. I put this thing, TRP is dead. The coffin is closed. I put in my Facebook page. I thought I'll make some cheap publicity. Somebody will talk about me. There'll controversy come. Who started this thread? Dr. Muruganandham. Oh, you'll become popular. The no publicity is the bad publicity. Any publicity is a good publicity. So then next day I put the TRP is dead. Next, nobody looked at me. The next day I put the people who are doing PCNL now in the face of the fans, they are criminals. I put it in the group. There was no response. Oh, this is also not working. That is slowly I'm going to the failure of that mode. Then I made the action heroes, lights, camera, action. I shoot a camera along with my colleagues, opening the theater door and my coat waving here and there with the background music and the lighting all around and scrubbing with the overhead lamplight and the loop. I took a photo and removing my specs and showing this. I just finished a 14-hour surgery. All these things I started projecting, but nobody looked at me. Again, it's a failure. Then I thought we'll go to the step 2, obsessive compulsive teachers. Oh, we have to teach everyone. Every student has to get a teaching from me. I know the entire thing. So I started a YouTube channel. I created a special playlist on do it yourself surgeries. For the first year MCH students, I have put how to do circumcision, how to do transplant, how to do robotics, entire thing I started teaching them. Then another special section on do it yourself surgery to the patient themselves. At least somebody make how to remove your foreskin yourself with a Swiss knife. At least I saw one comment in that. I saw one comment in that. I was so happy. I went and saw. He said, I have removed my prepuce already. You teach me how to remove my appendix, doctor. He has put in that group. So do it your surgery. But I saw slowly we are becoming popular. But is no, I have become not popular. As no, still nobody called me. Then before and after picture, you teach. The people teach. The PCNL, X-ray, after the PCNL, complete disappearance of all the stones, not even in dust. Even the rib calcification disappeared with a nice looking stent only. I put in that, no response. Then I put my before and after urethroplasty, uroflowmetry, the post-op uroflowmetry, Qmax hitting the sky, and the uroflowmetry metry. And the uroflowmeter actually went into a jam because it could not accept such a high Qmax, but still nobody looked at me. Then our plastic surgeons, they were very good. And they put before and after pictures. One of my friend, he has put the rhinoplasty picture, profile view, the front view. He put the rhinoplasty before and after. He said so many likes. One of them put the nice nose job done, doctor. Then I was excited. I put my hand job on the dick. No, I put a penile prosthesis. Before and after picture. But I did not get any comment, but I got a vulgar content warning from the Facebook. They removed me from the Facebook. So it did not work for me. So then slowly I became very desperate now. The frustration was picking up. I have to somehow become my last attempt to the third one is the craving, the novelty craving. Okay, what they do, they try to something new equipment they'll buy, they will show cause, they will do pictures with the robotic machine, then they upgrade the robot, they will tell it's a S, X, XI. No, it will go on. Actually, I am waiting for the Da Vinci triple X. I think then only I'll become very popular now. So, okay. The third one, what they do is if they actually this in improving your equipment needs for a capital cost, which is not affordable in a corporate setup like that. Then what can I do is the technical modification, small changes, what I can do in my techniques. Then I thought this will suit for me. What are the things we do? See, off late after COVID, I started seeing we were doing the prone position PCNL for a very long time. Okay. Yeah, we are doing a PCNL in a prone position for years together. Suddenly during the COVID period.
Let you know tomorrow.
Yeah. Yeah, I'm going to finish very soon. So this PCNL on the supine, they suddenly people started doing the supine position. That became viral. People who had started doing PCNL, they were called in all the conferences, they were the heroes. Then another thing, just when we were learning how to do retropubic prostatectomy with robot, then people started doing from the bladder. Let's say a sparing approach. Then they claimed the success rate is 150% because earlier they reported already 100% continence. So this is how to do. Actually, it's very painful. By the time we learn something and we are into that, the people are going to the next level. These are all the problems like people like Gill. They himself told we have to create the surgery and kill that.
Correct.
So that is a problem for ordinary mortals like me. We get trapped into these things. So then I thought, what we have to do? Then I thought, okay, well, I have to do something new which is in my setup. Can I do, see, this prostatectomy we do in trundle position. Can we do in the prone jackknife position? Or can I go and remove the prostate by cutting into the rectum and quickly remove, become famous? No, but that can form the rectal fistula. It's not nice for the patient. Then I thought, actually, can we do the hydrocele with the laparoscopy? But that can injure the testis. The next one I thought, can we transplant the kidney into the axilla? But where will I put the ureter? But it was something I have to do. I have to become popular. I am desperate. So whether I can put the kidney into the axilla, but where will I put the ureter? Okay, we can put it in the mouth. Oh, it's not nice. Then I dropped the idea. Actually, like that, so many ideas came. I was quite confused. Then finally, I got a beautiful, the life-changing idea of doing a circumcision in the prone position. I think that is very simple. It is. Then I thought, well, then I created the story for that. The surgeons, they suffer a lot to do the circumcision because they have to lean down, see that the organ of interest will be dangling here and there. They have to take stay and all. It's extremely difficult to do the circumcision in prone position. Then I thought I'll make a hole in the table, make the patient supine. The surgeon can sit down under the table, sit and operate comfortably. He can enjoy the surgery. Then my CEO asked, what is the advantage to the patient? I said, it is very obvious. Any dick will be so happy which is in some hole. Then immediately they rejected because they said I am too much very vulgar and sexual. I thought this advantage cannot be advertised too openly, and we cannot spend any money in making the hole on the table. You are out. So I became very depressed again. All the attempts failed. That day again I went into sleep, cursing Lord Ganesha, my favorite god. I thrown the statue out, but that day again the Lord Ganesha came into my dream. He said, why are you so upset? This time the Lord Ganesha was little different. He had not 6 packs. He got a big tummy and not with the cooling glass. He was cool, composed, with a slow walking. He come towards me, asked what happened. I said all the story. Bro, you are being cheated. What you saw was not a real Ganesha. He was my twin brother. He's a social media addict. He would have misdirected you. Who asked you to become popular? You enjoy your life, man. Don't try to be popular. Don't try to teach everything. You need not be good. What you learned, you spent years together in your medical schools, got from your teachers. Enjoy that. Don't try to become the real heroes. Be a real hero. So this is the final message I got from my favorite god, Lord Ganesha. Then I saw a peaceful face. Lord Ganesha blessed me. Now you get the peace. Enjoy your good working profession and family life. I said thank you to him. I say thank you to all of you. Thanks a lot. Thanks a lot.
Thank you. We enjoyed it.
On the subject of circumcision, I just wanted to add, one of my patients asked me, can circumcisions be carried out at any age, or is there a cutoff date?
Very interesting. Actually, this is my first experience of the sit down stand up. Actually, this is normally we act. I perform.
So there will be a lot of anecdotes for every one of us, and which will be humorous.
Try it in a prone position next time.
Muruganandham.
Yeah, now I converted to
a lot of people
Muruganandham.
who come to PGI from South India don't know Hindi.
Yes. Yeah.
So one of my classmate colleague, he did not know Hindi, so he was put in bedside duty. So the professor called, "Arey Baba ji ka hal kya hai?" This fellow looked here and there. Sir, hal number 3.
Very interesting.
Great.
Thank you. We had a nice time. Thanks a lot.
Ma'am, can
Thank you, everyone.
Yeah, ma'am, thanks what we can give, and then we can sign up, ma'am. Thanks to Prabhakar, and thanks to Murugan. I think thanks to Malik and Anil, they were there glued to us, listening to the fun which they both were creating. Yeah.
I think one suggestion is you can add one of these, humor in as a part of USI. Just to share a lighter moment.
Yeah, that's what we are thinking. Just let us see how it works out. Yeah, just let us see.
Thank you.
ISU evening we can do it. We can, if we can't. Anyway, So thank you very much for everybody who have stuck till the last, and definitely Dr. Prabhakar and Dr. Murugan, we enjoyed your talks, and hopefully we'll have more in the future. And I think everybody of us has a story to tell, and it will be nice compilation if all of share our stories together. I think we had a good evening with honoring our teachers, and they also spoke to us from their hearts. And I'm really thankful to everybody who attended. And thank you to Chawla sir and Bobby for helping me and carrying out this program. And thanks and good night to everyone. Happy Teachers Day.
ma'am. Thank you. Thank you.
Thank you, ma'am. Good night.
Thanks a lot. Thanks a lot.
Good night.
Thank you.
Bye.
Bye.
Thanks. Bye.
Thanks.